Hi, everyone, and welcome to the Muslim Sex Podcast. Thank you so much for tuning in. I really appreciate your patronage, and I would love it if you could leave me a 5-star review because that really helps me. And if you could like and share this episode with somebody that you know that may benefit, your friend, your colleague, anyone, I'd really love you to share this podcast, especially if you find value in the Muslim Sex Podcast. Also, I'd love for you to subscribe to my YouTube channel and follow me on all my social media. Also, as you probably know, if you've been listening to this podcast, is that I have a practice that is now open in Chappaqua, New York. I see patients for menopause and sexual health, as well as regular gynecology. So if you are looking for a gynecologist that actually spends time with you, that has time to listen to you, then I would invite you to come and see me in my practice, and I'd be more than happy to take care of you. So make sure if you live in the New York area, or even if you don't, come and see me in my office. I'd love to meet you. And also, last but not least, is that I am hosting again my retreat in Morocco for 2025. So if you are looking for a gift for a family member, a friend, yourself, make sure you take a look at our retreat, the Love and Nourish retreat. It will be held September 19th through the 26th, 2025. Again, this year in Morocco, we will be visiting the same towns. We will be in Marrakesh and Essaouira. And as always, we will be providing information and lectures on menopause, perimenopause, nutrition, and also going for cooking classes as well as excursions. So don't miss out. I know a lot of people were sad when they missed out this past year on the Morocco retreat. So make sure that you go and visit the Love and Nourish retreat hosted by Caria Retreats. And now onto the episode. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about thyroid function and menopausal symptoms and how sometimes it can be hard to make that distinction. But before we get into it, a few things I want to make clear. Of course, I'm not giving any type of medical advice. So if you have any questions about your health, please go speak with your healthcare provider, and definitely not giving any advice about religion. So if you have any questions about your religion, please speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So I am very happy and excited to have on with me again Dr. Dana Gibbs. If you missed our first episode, make sure you go check it out. Dr. Gibbs telling me that it was 2 years ago?
May of 2023.
Oh my goodness, so long ago. So yes, go check it out if you missed it. And so today we're going to go and talk a little bit more about thyroid disease and menopausal symptoms, and sometimes how the two can be very confusing and hard to distinguish. And so it's really important to go to somebody that knows how to figure that out. So Dr. Gibbs, if you could please introduce yourself to the viewers and guests that may have missed your previous episode, and let us know where you're calling in from and what you do.
Sure. Thank you for having me here. This is great fun to be back. So I am Dr. Gibbs. I am a private practice physician in Texas. For 23 years or so, I was full-time ear, nose, and throat and thyroid surgery and ENT, allergy, and sinus and all the random things that happen from the neck up. However, a big part of what I did was treat thyroid disorders, which I know sounds a little bit weird since they're also endocrinologists, but because I was doing people's thyroid surgery and I saw them back and sometimes they were not doing well, I began treating their non-surgical thyroid issues as well. So that kind of tended to organically spread into the other hormones because unlike what it feels like mainstream medicine kind of silos the different hormones into different specialties and never the twain shall meet. But hormones affect other hormones, and thyroid affects cortisol, affects sex hormones, affects insulin, affects everything. And so gradually, as my knowledge base grew and my experience grew, and as I headed towards menopause myself, I realized, you can't just do one, you got to do it all. And so this past year, I got certified by the Menopause Society and added that to my now exclusively hormone based practice. So that's
Amazing.
where I'm at.
All right. Woohoo. Another Menopause Society certified practitioner. That's
I know. I'm
amazing.
so excited about that.
Yes. And can I tell you that I love the fact that we're matching? Not that it was on purpose, but
Yeah, we did not communicate ahead of time about that. I think that's
no.
awesome.
Yeah, it is awesome. So tell me more. So I want to know more. What I think and what what you say is absolutely correct. That sometimes it can be hard to distinguish between, thyroid symptoms and menopausal symptoms because you can feel hot, right, with both of them. And if your thyroid is really high, and you can have a lot of symptoms like your periods can be irregular, right? When we're in perimenopause, your periods can be irregular. They can be irregular with thyroid function. I'd love to talk more about this and why it can be so hard to distinguish the two.
Yeah, so I actually made up a list. I knew we were going to talk about this ahead of time, so I actually made up a list
Amazing.
of symptoms,
Mhm.
and the list is actually a list of menopause symptoms. But when I look at it, I'm like 90% of these symptoms can also be thyroid, and
Mm,
so I just thought I'd read them.
yeah.
So anxiety, being overly worried or tense or feeling stressed out, panicky, overwhelmed, depressed, all of those things can be thyroid or
Mm,
perimenopause.
mhm.
Brain fog, difficulty
Oh, yeah.
focusing, forgetful, poor word finding, distraction, feeling out of it, executive function. So, brain fog. So, I mean, we're going to touch every system of the body here. So, fatigue, low energy, easily getting tired, sleep disorders,
Yeah, right?
waking up with night sweats, trouble falling asleep, trouble staying asleep, being very cold when you first fall asleep tends to be exclusively thyroid, but the rest of it, you can't tell the difference.
Mm,
Headaches, some uh, worsening headaches, heart palpitations. We also already talked about hot flashes and night sweats. Then irritability. That's very, very common for hyperthyroidism more than hypo. But if you're fluctuating because you have like Hashimoto's disease or something, then yeah, it's easy to get frustrated. It's easy to get quick to anger. Joint pain, joint and muscle pain, common to both, especially in the extremities, knees, ankles, fingers, wrists, feeling stiff and creaky. Libido problems, diminished sex drive, just diminished a desire for anything sometimes.
yeah.
And then period changes. It can be either diminished flow and lighter, less often cycles, or it can be shorter cycles or skip cycles or extreme pain with cycles. And then hair and skin changes, dry,
Mm,
itchy skin,
yeah. Mhm.
thinning hair. Um, and then we already talked about sleep. And then, of course, weight gain.
Yeah.
Weight gain. Ugh,
Oh,
weight
that's
gain
huge,
is
right?
everywhere.
No, no
So, I
pun
mean, there were
intended.
only two symptoms
Yeah.
off this list that I didn't mention. One of them was urinary tract infections. One of them was painful sex. And it's just like every single thing else on here is common to both. And I'm like,
Yeah.
dang, wow.
Wow. Yeah. Right. And, had you not gone through that whole list, I don't think I would have put the two and two together. So you're so right, right? Like it's so hard to make that distinction. And I think one of the best ways probably to do it is, one, the age of the patient, right? That can probably help a little bit, kind of looking back at what
Mhm.
their medical history has been, but
Sure.
also, of course, drawing blood levels, right? Checking the thyroid hormones, I think will
Yes,
definitely help.
absolutely.
How do you make that distinction?
So, because thyroid issues can occur kind of at any age, I mean, I've seen
Yeah.
Hashimoto's disease in kids as young as 7.
Wow.
I've seen it in as high as I have one patient now who's almost 80 and she's still got her issues with her Hashimoto's. Perimenopause tends to be in the between 40 and 50, but it can go earlier, it can go later. And And if you already have thyroid issues that you don't know necessarily about, then going into perimenopause is going to make that problem worse. But there's also the issue that 50% of the onset of Hashimoto's disease, and we'll need to define what that is in just a second, 50% of the onset of Hashimoto's disease is during the menopausal years. And
So
so it's just like, bam, they're together. And
hmm,
so just because you have one doesn't mean you don't also have the other one. And it
right.
can be really tough to figure it out.
Hmm.
Um, so I mentioned Hashimoto's disease, and let me just define what that is. So Hashimoto's disease is an autoimmune condition that can occur as a result of stress, and perimenopause is pretty damn stressful for most people. It can occur as a result of stress, and it's an autoimmune condition where your body decides that something in your thyroid gland is foreign and starts attacking it and damaging it. And it can lead to intermittent bouts of very high thyroid. And it can also lead to progressively lower thyroid. And it can also lead to a situation where, according to the traditional definitions, your thyroid levels are normal, but your your body doesn't process your thyroid hormone correctly anymore, and you feel the symptoms even though your TSH looks fine. So there's three different ways that Hashimoto's disease can jam up your thyroid function as that goes. And so even somebody who's got, and this was my personal experience, even somebody who's got very well controlled thyroid issues, when you head into perimenopause and your hormones start fluctuating, it just turns everything on its head and all those symptoms come back. And then you don't know, is it my thyroid? Is it my menopause? You don't know. You don't know. And many women don't even realize that's what's going on. They just think, holy cow, my life sucks and I hate my husband and I'm I'm ready to throw my kids out onto the street. And they just, the mood changes are just phenomenal. And they don't even realize, hey, you know what? My thyroid isn't as well managed as it was. And now I've also got these hormone fluctuations that are messing things up. So yeah, it can really be very, very tricky to get things back balanced again if you
Yeah.
already had one and then you go into the other, or if you end up with both at the same time, then it's just like poof, explode your
Yeah.
head.
Yeah. Well, that's why it's so important to have a doctor that understands all this, right? And all the nuances. And that's why somebody
Yes.
like you is so important because, you understand thyroid so intricately. And you also now, are certified as a Menopause Society certified practitioner. And I'm sure even before you were a Menopause Society certified practitioner, you understood menopause, but now even more intimately. So I think
Yeah.
that having somebody like you as a resource is so important for somebody that may be going through both of those things at the same time, which,
Yeah.
like you said, can be really tricky and hard to figure out. So, what tests would somebody get done if they were experiencing all of these symptoms? Would you do the typical like thyroid test, the TSH, the free T4, all of those? Would you do like an antibody test? I guess if it was Hashimoto's, you would have to do an antibody test, right? Or figure
Sure.
out if,
So here's the thing about perimenopause is that mostly it's a symptomatic diagnosis,
right.
especially due to what the Menopause Society teaches is that really checking the sex hormone levels is not super helpful.
Right.
Now you can go in and you can check LH and FSH, or you can go in and you can check anti-Mullerian hormone and get an idea of, okay, my ovarian reserve is starting to get low. My FSH and LH are starting to rise. And you might have to do that test a couple of different times before you caught it because they do fluctuate. To know, okay, is there any contribution from perimenopause right now? And that's important to know because it just complicates things. But as far as the thyroid issues, you hit upon one thing which is really important is that if you don't know what your status is in regards to Hashimoto's disease, it's important to at least get that antibody test done one time and see, okay, do you have antibodies related to Hashimoto's? If you've ever had a thyroid nodule, which is a lump that comes up in your thyroid gland, most are benign, but if you've ever had a thyroid nodule, that can push us towards, okay, I think you probably have active or have had Hashimoto's attack on your thyroid gland at some point in your life. So it's important to know that. It's important to know that status. And then after that, then I do not just test the TSH and free T4, although I do test those because it's important to know those. And truly, if your TSH is abnormal, then there's definitely something wrong. The problem is if your TSH isn't abnormal, then you can't automatically assume that there's nothing wrong. And that's kind of my main focus, especially when I'm trying to encourage other doctors to look beyond the guidelines and go, okay, there's nothing wrong with the guidelines. They just don't go deep enough. To encourage other doctors, okay, please check the free T3. Please check total and reverse T3 and look to see if there's abnormal thyroid signaling going on, in addition to, is there enough thyroid hormone? So that's really important. Is your body processing your thyroid hormone in a way that makes it accessible to your cells so that you can have energy, so that you can grow your hair, grow your nails, not be constipated, not have gut problems, not have, the extra contribution to the fluctuating sex hormones, which you get when you have low thyroid signaling.
Yeah, so important. There's oftentimes in infertility, and I know we're not talking about infertility, we're talking about menopause, but I remember when I would have some patients come and talk to us about, they were trying to get pregnant. And so if we ended up sending them to infertility specialists, they would go to them, and then the infertility specialist would start treating them for subclinical hypothyroid, meaning like the labs didn't show it, but they thought that perhaps they had it. And then the
Mm-hmm.
patients would, get pregnant because all of a sudden now their thyroid was normal, even
Yes,
though the labs weren't showing it. What do you think about that?
I absolutely agree with that way of dealing with things, and let's just go into a little bit of detail about that because that's kind of important. So the TSH test is considered to be in the reference range if it's between zero point 0.4 and about 0.45. And that's for most labs, that's about what the reference range is. The infertility specialists take that down and they say if it's above 2.5, we're not happy with it. And
Mm,
that may mean that you don't have enough thyroid hormone in your body to carry a pregnancy. And so early trimester miscarriages is a super, super important thing and really common in abnormal thyroid signaling. Subclinical hypothyroidism is where you may or may not have symptoms that you've noticed, but your TSH is above that 4.5, but below 10. And then, so they're going to look at that and go, okay, your thyroid function is marginal. And that's what it means to me as well. It's like your thyroid function is marginal. If we want the highest chance that you're going to carry pregnancy to term, we need to be supplementing thyroid. But what the reproductive endocrinologists generally are not doing is that they're not using any T3. They're not
mm,
using any desiccated thyroid or any compound that contains any T3 in it. Whereas my approach is a little bit different because of some patients that I have seen. I'll just describe one. So this lady was not menopausal. She was 31 years old. She had not had a period in like 5 years.
oh my goodness.
She had a normal TSH, she had a normal free T3 and a normal free T4. But what she did have was very, very high levels of something called reverse T3. And She was already taking thyroid medication when she came in. But despite that, she had this very, very high level of reverse T3. And what reverse T3 is, I've heard it called, this was something new that I heard lately. I've heard it called the hibernation hormone, because what it does is it goes in and it blocks the activity of the active thyroid hormone in your body.
Mm.
And the higher it is compared to the amount of T3 that you have in your body, the less likely you are to have optimal thyroid signaling and the more likely you are to have symptoms. And this woman had had 3 miscarriages in short succession, and then basically stopped having periods altogether.
Mm.
And she also had the cold, the tired, the hair falling out, all the things. She had all a lot of those symptoms. And when we brought her in, we look at something called the T3 RT3 ratio. And the reason we need that is because reverse T3 is present in such small quantities in your body that you cannot just compare it directly to free T3. You can't do that. It is the free plus the bound. It's the total amount of reverse T3 that you have in your body, and so you have to compare it to the total amount of T3. So the total T3 number, and both of those numbers by themselves are not super helpful. I mean, they can go way up and they can go way down with a lot of different activities. And a lot of them are related to sex hormones. They are, do you have, because sex hormone binding globulin, which is something that is circulating in your bloodstream and helps carry the sex hormones around in your bloodstream, tracks very carefully, very closely with something called thyroid binding globulin, which is the same purpose, but it's for thyroid hormone. And then there's also other proteins in your blood that carry those thyroid hormones and those sex hormones around in your bloodstream, because otherwise your kidneys would just pee them out. They would just say,
Mm.
they're water soluble, bye, they go away. And so they track together. So if you have high estrogen levels, you're going to have higher hormone binding globulin levels. If you have low thyroid levels, you're going to have low hormone binding globulin levels, and they go up and down together. So when you have your period, it goes up, it goes down. If you are on birth control pills, it goes down. If you have insulin resistance, it goes up. So you cannot compare one to the other. And so we use a ratio. We say, okay, total T3 divided by reverse T3 equals some number. And that some number, when it's normal, is between about 10 and about 14. So there's 10 times more T3 than there is reverse T3 when they're both bound to protein, and you're comparing apples to apples that way. So if you have that number and it's between 10 and 14, then I'm really, as long as the other three thyroid levels, the TSH, the free T3, and the free T4, as long as they're in that normal range, I'm not worried about your thyroid. I'm saying, okay, everything's good. Let's move on to cause B and see what else we can find. This lady that I'm talking about, her ratio number was 2.5. So she had a very, very high amount of reverse T3 compared to her T3, even though her T3 was normal, even though her TSH was normal, even though her T4 was normal. And when that was corrected by giving her extra T3, which allowed her T4 and her reverse T3 to fall somewhat, then all of a sudden she got pregnant and she carried that baby to term. And actually, she was
Wow.
able to go and have a second child, which she was extremely happy with. And she did not need fertility treatments. All she needed was getting that thyroid corrected. So it was kind of a crazy
Wow.
story.
Yeah, no, that's amazing. That's fantastic. What a great story.
Yeah, it is. It really is.
Yeah. So I know you made mention of the sex hormone binding globulin.
Mhm.
We know, actually, I think in with birth control pills, it actually goes up.
Oh, it
because
goes up. Okay.
yeah, it
I
goes
had
up.
forgotten.
And so, because then it'll bind to testosterone, and then when it binds to testosterone, it decreases libido. That's how sex hormone binding globulin.
Yeah, I think you're
Right.
absolutely right. I think you're right. And maybe I'm wrong about insulin too. I'm thinking high insulin makes it low and sex hormone binding globulin makes it high.
Yeah,
I think
I'm not
that's
sure
right.
about insulin, but I know that for a fact, with birth control pills, and that was written up last year in the New York Times article about how birth
Mm,
control, yeah, it affects your desire. So it decreases libido by
hmm.
increasing sex hormone binding globulin. It binds to testosterone, decreases your libido, but also it can cause vestibulodynia, hormonally mediated vestibulodynia, because it will
Hmm.
downregulate the receptors in the vestibule and
Yeah.
cause the irritation of that vestibule. And that's why
Hmm.
some women can have pain with intercourse that have been on birth control pills for a
For a
prolonged
long period of
period of time.
time.
And in fact, they say that if you start birth control pills less than the age of 17, you have a higher chance of developing this vestibulodynia than if you start them greater than the age of 17. And I assume it has to do
Wow.
with the receptors and
Mm.
yeah, being downregulated. So
Wow, that is really interesting. And I wanted to ask you a question because I actually see similar things like that. And I
yeah.
wanted to ask you how long after someone stops taking birth control pills does that problem go away?
Yeah,
Or
I think
does
it's
it go away?
right. I think what you need is that not only, I think it takes a while. I could think it can take a few months, but also you need to treat them with the estrogen and the testosterone. And they said within,
Oh,
when you apply the estrogen testosterone, it's applied to the vestibule twice a day.
it's a
50%.
topical. Uh-huh.
Yes, yes, it's a topical ointment. Um, or it can be a cream, but ointment absorbs a little bit better.
Hmm.
And a 50% resolved by 12 weeks and 90% resolved by 9 months. So it can
Wow.
take a little bit of time, yeah, for that vestibulodynia that's caused by birth control pills to be fixed. So that's why
Wow.
it's really important
That's
to know.
that's really that's really a little bit scary to me because there are so many other conditions that we give people birth control pills
Oh, all the
besides
time.
actually preventing pregnancy. So that's really
Yeah.
a little bit frightening.
Yeah, it's unfortunate, right? Because right, we use it, sometimes we use it to regulate periods, sometimes we use it to for endometriosis, sometimes we use it for acne, sometimes, where there's just so many reasons why we use, and we give it out all the time, right? Like water, we just
Yeah.
give it out. I mean,
Yes.
it's
Yeah.
it's really funny how that happens, and
Hmm.
really important to know that the side effects that it can cause. So
Yeah.
I'd love to know more about menopause and thyroid. So once we think that the symptoms are being caused by menopause, that as opposed to thyroid, what would help you make that distinction? Would it be just that all of her thyroid symptoms were normal? I mean, of course, we know that with menopause, like you mentioned, you have the gender urinary syndrome of menopause. But what other things would you use? I mean, I assume, of course, obviously, we want to take a look at the FSH, LH, AMH, estradiol. We want to take a
Hmm.
look at those values to make sure, see where those are at, right? And we
Yeah.
know that if you have a FSH greater than 25 times 2, then, they're definitely in menopause. Um,
Yes.
Estradiol level, I believe it's less than 20, AMH level of 0 will tell
Hmm.
you that a
That's
person is in
definitely
menopause.
menopause. Yeah.
Yeah,
I mean,
yeah,
the harder part of it for me is the perimenopause because things are
yeah,
fluctuating so much.
right.
And it's unfortunate, but when I was going through menopause, and it's been more than 10 years ago, my doctor actually put me on pellets. And I'll just use this as an example, because what pellets do is they cause your sex hormones to go up really high sometimes, and then they go down, 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 and then they go up, and then they go down. And because that changes the levels of the binding globulins, it also changes your thyroid. Now, you're taking your thyroid medicine every day. And so, for a period of time, you have way too much thyroid hormone, and then you don't have enough, and then you have too much, and then you don't have enough. And so I was changing my thyroid hormone like 3 times a year, and it was this crazy roller coaster ride of I just feel horrible all the time. And it took me quite some time to figure out that it was actually the pellets that were doing that. Um, and to switch over to a more steady dose. But the natural history of perimenopause is that the hormone levels go up and then they go down and then they go up and then they go down. Um, and they do it sometimes fast enough that you just can't keep up. And so are there are times when it really does feel like you're chasing your tail sometimes, trying to get that leveled out for people. And the way I tend to handle it is I really try to be as precise as possible in when I have them go to the lab. So, like, I want them to go to the lab, one, when they're mid follicular, which means about 4 days after they have started their period. And I also want them to go to the lab at the same time every day. So the thyroid medicine is dosed, most people dose it once daily. I actually prefer twice daily for some reasons we can talk about in a minute if you want to. And so I send my people to the lab 6 hours after they took their morning dose. So it's usually their lunch break, so they can manage it. And I say, okay, if you took your thyroid at 6:30 in the morning, go to the lab at 12:30. Have them stick you right at 12:30, as close to that 6 hour point as you can. And so that what that does is it gives me a mean. It gives me a halfway between the peak and the trough. And the more precise they are with the timing of when they take their thyroid medicine, and the more precise they are with the timing of when they go to the lab, the easier it is for me to say, okay, it looks like you're having a little too much, or it looks like your T4 is too high and your T3 is too low. And we need to adjust the percentage just a little bit or something like that. And so that's basically the way I handle it for somebody who's in perimenopause. Now, once you get to actual menopause, then you're not ovulating anymore. And so then it becomes a little bit easier again to get it under control. But I still like that precision in the lab testing as far as the time of day when people go.
That's really interesting. So you were saying that you prefer patients to not do a daily dose of thyroid, but twice a day. So why is that?
Sure. So when you look at blood levels, so if you send somebody to the lab 5 or 6 times during a day, and I don't do that, but people who are doing research have done that. And what they say is that the amount of thyroid hormone in your blood can vary 30% or more from 2 hours after you took your thyroid pill to that hour before you take your next thyroid pill. It can go up and then it can go down. And most doctors who are being precise and telling people, okay, you need to go at a certain time of day, they're telling people to go in at a trough level. They're telling them, skip your dose this morning and go to the lab as early as you can. And so you're getting it's been a full 24 hours since you had a thyroid dose. And so they're getting what it is when it's at its lowest, but what they are not getting is what is it right after you took your pill? What is the highest you get? And so I very frequently see people that I think are overdosed on levothyroxine in particular. And that overdose, that high level right after you take your pill, triggers your body towards blocking. It triggers your body towards making more of the reverse T3, which no matter how much T4 and no matter how much T3 you have, if you have that high reverse T3, you're going to feel like your thyroid is low. Now, you can still have some side effects of high. You can still have the palpitations, but you may have the other effects making you feel like, okay, I'm cold, I'm constipated, I'm this, I'm that. And so I find it very helpful. The ideal world would be to have a pump, like we have an insulin pump where they take a tiny, tiny little dose continuously throughout the day. For T3 in particular, because it does last such a short time in your body. But T4, the same. I really think that way back when Synthroid was first marketed as a once a day medicine, they didn't even get it FDA approved. They didn't even do the pharmacokinetic studies to prove that it was okay to do that. Um, that was never proven as an okay thing to do it. And before Synthroid, thyroid was dosed 3 times a day, not 2 times a day. And I think that we've all I say doctors, have been a little bit bamboozled into thinking that it's fine to give thyroid once a day.
Hmm.
And I really don't think it is. And my patients feel much better when they don't.
Interesting. So, if you were to leave any lasting, say, quick pearls for somebody that may be wondering, is she in perimenopause? Are these perimenopausal symptoms? Are these thyroid symptoms? What would you say is like a clinical pearl or something that you would leave them with that they could maybe help to make that
Sure.
distinguish it?
And it would depend very strongly on it, are they already on thyroid medicine or not. So if they're already on thyroid medicine, then I would do 2 things. And you can do this whether your doctor tells you to or not, is you can first of all break your thyroid pill in half and take half in the morning and half at bedtime. So that's the first thing you can do. And that will blunt the highs and it'll blunt the lows enough that sometimes people will actually feel quite a bit better. The second thing you can do is you can make sure that you go to the lab at the same time of day every single time you go. So those are 2, I always tell people to do that. That's just number 1 thing. And then the next thing is, if you've had a TSH and it was fine, and your doctor said your TSH is fine, there's nothing wrong with your thyroid, but you still have that same list of symptoms and you're still concerned, because it's not like they come and go with your hormones like they were menopausal. If they're just always there, then you can now in the US go and request a set of labs and just pay for them. If you can't talk your doctor into ordering the set of labs that are the ones that I mentioned, you can just go and pay for those labs. And I am actually doing, in probably next month, I'm going to do a group program where people can come in and order their labs and bring their labs in, and we'll do a session where we just analyze people's labs. And I say, okay, yes, I think, yes, you have thyroid issues, or no, your thyroid issues, your thyroid looks great and it's got to be something different. It doesn't mean nothing's wrong with you. It just means this is not thyroid. So I'm going to be doing that in the next several weeks, and I'm pretty excited about it as a pilot program, because, and I feel like more people need to know about this. And so the other thing I'm doing is I'm going to go back and start the course, the physician's course that I do for docs who want to learn more about this. We're going to start in probably mid-April, and we're going to do the whole course again on integrative hormone management. And I'm super excited about that, because I think my mentor, Alan, who teaches that class, is getting ready to retire. And I don't know how many more times he'll do it. And I'm a little bit intimidated, frankly, to take over teaching that to other doctors. But I'll do what I have to do, because I really do feel like this is important. And I wish more doctors knew what it is that I know.
Yeah, absolutely. I think that sounds fantastic. So for those people that are listening that are wondering, like, wow, I'd really love to work with Dr. Gibbs, really love to know how I can get in touch with her. How can they get in touch with you?
Okay. So my website is www.danagibbsmd.com. And the course sign up list is on the website. And the newsletter sign up for my patient newsletter is on the website. I also have a platform on an app called Good Self, where I do Q&As every week. And That app is free to the user. So it's really, really exciting and fun. And you should come on there and start doing talks because it's really cool. And then I have a podcast. I have my own podcast that I've started since I been on yours last year. And I go deep on all these different thyroid topics. And so if there's something that you want to know about thyroid, you can send me an email. And if it's something that I think other people would benefit from knowing, I'll do a podcast episode on it. And so my email address is drgibbs@danagibbsmd.com.
Very cool. Thanks. This has been fantastic. So, what is the name of your podcast? You didn't tell us the name.
Oh, I'm so sorry. You're right. I didn't. It's called Beyond the Thyroid. So it's thyroid and hormone topics for an integrative audience.
Excellent. Well, this was fantastic. So thank you so much for being here. And well, it's been real and really intimate. And of course, this was not meant to be any type of medical advice. If you have any questions about your thyroid or any other health condition, definitely go speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.